Okay, good afternoon, everyone. Good afternoon, everyone. We're going to try that again. Good afternoon, everyone. How are we feeling? Energized? Inspired? Ready to go? All right, okay. Well, good afternoon. I am Tanisha Sullivan. I'm the head of external engagement and health equity strategy here at Sanofi. I want to welcome you. Some of you I welcomed earlier today. I want to welcome you again. And for those I haven't had an opportunity to welcome, welcome. Y'all can laugh at that. That was a little, okay. I am truly thrilled to moderate this next panel discussion, health equity evolution. What's next in research, policy, and practice? We need all of it. What's next in research, policy, and practice? And I'm joined by some of today's leading voices in public health, academia, research, and practice. All of them leaders truly on the front line when it comes to this work. Today, we'll explore how policies and initiatives designed to address social drivers of health can continue to advance and meet the needs of underserved and under-resourced communities and patients. I'm joined by Dr. Rita Hamad, who is an associate professor at the Harvard Chan School of Public Health and the director of the Social Policies for Health Equity Research, or SPHERE Center at the Chan School. Also joined by Marjorie Decker, who is a state representative representing the 25th Middlesex District here in the Commonwealth of Massachusetts. Dr. Robbie Goldstein, who is our Commissioner of Public Health here in the Commonwealth of Massachusetts, and State Senator Liz Miranda of the 2nd Suffolk District. We don't have much time. The clock is ticking, so I'm going to move. And I'm going to start with Dr. Hamad. Dr. Hamad, can you just help to frame the landscape? What's happening on the ground today in communities? One that is working, and then what's also happening on the ground today that gives you hope for tomorrow?
Yeah. So just to start off, thank you for having me here, and thanks to this audience who's been amazingly engaged today. So Tanisha, as you know, I'm trained as a family physician and as a public health researcher, but I actually see it as my job to convince people that the best way to address health equity is outside of the healthcare system and often outside of the realm of public health. And actually, we know social determinants of health are major drivers of health. To start thinking about those upstream policy, political drivers of health that really are really potentially powerful drivers of health equity. So my team, the Social Policies for Health Equity Research Center, one of our main goals is to try to understand those social and economic policies that have the maximal potential to improve health and health equity in communities and at the state and federal level. I'll give a couple of specific examples of ones that we know work very well. So one of the policies that my team has done a lot of work on, and a policy that actually has a lot of evidence behind it, is the Earned Income Tax Credit. So raise your hand if you've heard of the EITC. So yeah, not quite half. And so that's, might surprise you because it is the largest U.S. poverty alleviation program for families with kids, and most people haven't heard of it. And so, the way it works is that low-income working families file their taxes at tax time every year, and then they get a really large refund, an average about $2,500 up to about $7,000 and more with the state EITC programs. And we know that the EITC is really impactful at improving poverty, at improving housing security, and a lot of the work that my team does shows that this has direct impacts on improving health and health equity. For example, improving mental health, improving birth outcomes, improving food security, and so really a policy that has a lot of potential impact. And we know that this policy also has some problems. It does require filing taxes, which can be complicated, and it's only given once a year with that tax refund. So families often run out of money later in the year. Just to give another example, another really important safety net policy that addresses upstream drivers of health is WIC. So that's the Special Supplemental Nutrition Assistance Program for Women, Infants, and Children, the WIC part. And so this is a policy that serves low-income, pregnant, and postpartum women and kids under 5. It provides food package once a month, as well as nutrition counseling. And my team and other teams have shown that this policy improves pregnancy and birth outcomes, it improves food insecurity, and it has long-term impacts on health and economic self-sufficiency. And this is just a couple. I'm not going to list all the alphabet soup of safety net programs out there, but we know that a lot of these programs work really well. We know they have their limitations. I mentioned a couple of them for the EITC. For WIC, it's a great program, but it's very limited. It offers like 1 or 2 loaves of bread a month, $50 of cash benefits for fruit and vegetables a month. But despite these limitations, we know these programs are effective, and the reason they are effective at improving population health is because they're not embedded necessarily in the healthcare system. They can reach the entire population without people having to come and see their doctor, and they intervene directly on those social drivers of health like poverty, unemployment, food insecurity.
Thank you for that, Dr. Hamad. I think it's really, and we've heard it, I think, thematically throughout the day, kind of the connection, the intersection of economic mobility and health and well-being. So thank you again for really putting a fine point on that. Dr. Goldstein, I want to turn to you to talk a little bit at the state level. What are you seeing? So similar question, but what are you seeing at the state level that's working? But then give me 1 or 2 of the biggest challenges you're wrestling with right now.
Yeah, 1 or 2 is hard to do, but I will do that. I think it's great, though, to start with successes, because we have a lot of successes here in Massachusetts. And I'm a huge student of history, but I think we have to all remember we are the state with the first statewide health board that ever existed in this nation. We go all the way back in our health department to Paul Revere. Right? We have a very historic health department and a historic investment in public health. And that has allowed us to do a lot of amazing work through the Department of Public Health in collaboration with the legislature and with academia and all of our community-based organizations and partners. I wasn't going to talk about WIC, but I do just want to say one amazing thing about WIC. It is a fantastic program that is a true success story of public health, and we're still making it better. We're innovating. And this year we released online shopping for WIC enrollees so that no matter where you are in the Commonwealth, whether you have access to a car, a bus, a train, you can still get your WIC supplies delivered right to your door, which is pretty amazing. The success, though, that I wanted to talk about was the success of local public health, which is something that we oftentimes don't think about, but is so critical to this equation of how we address health equity, how we advance health equity. We have had a historic investment in local public health over the past 4 years. A lot of that came from federal funds. Much of that also came through the legislature. That has meant that we've built up the workforce in 351 cities and towns. And we've done it thoughtfully. We've built up the workforce with people who speak the language of their community. They look like their community. They sound like their community. They are their community. And by doing it that way, we're making sure that we can deliver public health at everyone's door. And I think that's a real success, and we're going to see the fruits of that in the coming years. There are a lot of challenges that we can talk about. There are a lot of challenges related to funding, related to the federal government, and to policy actions that are happening. But I would say that I think the biggest challenge when it comes to equity for us are the deserts that exist in this state. We think of ourselves as a small state, but we're pretty big. And I know you had something earlier today about pharmacies and the pharmacy deserts, but that story is true if you're thinking about reproductive health care access, if you're thinking about maternal health services, if you're thinking about gender-affirming care. It's true even when you think about things like where the WIC office is that you go to enroll and have your first visit. And I think we need to do some work to better connect the people across the state, the 7.1 million people, the 351 cities and towns, and do it in a way that is thoughtful about transportation needs, is thoughtful about where people want to get their care, who they want to get that care from, and how we can lift up those services.
Thank you. Rep. Decker, you are the House Chair for the Joint Committee on Public Health within the Massachusetts legislature. A lot of great work has come out of your committee, so thank you for that. Can you just share a little bit with us about the resources that legislators lean on to help develop policy that is actually going to help improve health outcomes in underserved and under-resourced communities?
Thank you, and thank you to you and to Sanofi and to the Globe for hosting this forum. Important that we continue to have spaces to have these conversations. I would say that for legislators, it's different how we all seek information, but what's probably fundamentally true for each of us is you have to start with the people that are impacted to understand what are the problems that you want to address and solve. And so it starts with who's being impacted, and then who's doing work around with impacted communities. I think the challenge of legislators is to always make sure that when we're looking at solutions, that there's a thread that ties directly to impacted constituents and communities. One of those examples would be I had the honor of co-chairing as the chair of public health, the Maternal Health and Racial Inequity Commission, which was created out of legislation by my sister in service here, Senator Miranda. And so together we were able to work with a commission that it was 28 people on this commission and 27 were women of color. And to legally even get that to be an outcome, I credit my sister here for getting that to happen. And it's never happened before in the legislature. So what it meant is that we had a report that came out that directly spoke to the harrowing and unacceptable statistics about what maternal health outcomes look like for women of color, both in Massachusetts and nationally. We were able to take that commission, which was a report, which was based on listening sessions throughout the state, and then also working with providers, specifically providers who work with predominantly birthing people of color in Massachusetts, to come out with a report. So that's an example of, that's probably to this date, probably the best example of how we should do it. And then the rest of it is about, we rely on advocates, we rely on constituents, we rely on, I know I rely on institutions of higher ed, play a really important role. We work with each other, state agencies, the Department of Public Health and my committee, our staff we have conversations frequently to figure out how we problem solving and partnering at the executive level and the legislative level. We rely on each other as legislators to bring the attention to various issues. So it is this collaborative process when it's done well. But the most important thing for me, and it's not always done this way, when someone says, I want to work on issue X, Y, and Z, I say, that's great. Now, what's your relationship to the community that will be impacted? Are they asking you to work on this? Are you sure that those are the outcomes that actually will solve a problem that people will tell you are the obstacles? And we all do it differently, but ultimately it starts with most legislators run because they love their community. We're seeing that is not always who runs and gets elected. The idea that legislators, there's this Hippocratic oath that doctors take, do no harm, and I've always thought that there should be a more formal term for legislators, right? Clearly, we really need one. But it's not only do no harm, but it's more about also going back to this question of who are we centering? Who benefits from this policy? Who benefits from this budget decision? Who benefits from the convening? Who's not at the table? Who's not being centered? Who's being harmed? And those are the questions for me that are that I thread through every action that I take as a chair of public health, but also as a legislator when I just look at bills that I file, or when we're just talking in committee hearings. Those are the questions that we have to keep asking ourselves. And part of coming to this, people have said, what does equity look like in the age of Trump 2.0? And for me, it doesn't change. It just means equity, we still weren't hitting the mark on making sure that those who need more, that we systemically understand why they don't have what they need, right? it is not an individual's deficiency, it's a structural system that by design is taking from people. And so that doesn't change. The work feels more intense, it feels more rapid, and it feels more urgent. But as legislators, the questions don't change and the process shouldn't change.
I actually, so Senator Miranda, I want to sit there for a minute. Because you've been in the legislature for quite some time now, both on the House side and now on the Senate side, on the state Senate side. Can you talk a little bit about how has the approach to policy making evolved to be more inclusive of the lived experiences that Rep. Decker described, and perhaps share an example of your own?
Thank you. I want to co-sign. It's so great to be here with these panelists. I actually met you today, and I've been following your work, and I get to work with these two individuals all the time and co-sign. You know, just happy to be on the same stage as you. So I've been in the legislature for 7 years, and for those of you that don't know my story, I came to the legislature after running after my brother's homicide. And, you know, I was in a tough race. I didn't know how to write a bill. I thought people that were in the legislature did not look like me, did not have the same lived experience. And I found out from my community that I was exactly the right person to run. The exact person that had been through some things, that wanted to change some things. And when I came to the legislature, I wanted to work on gun violence policies. And I really want to credit March of Dimes because a lot of people thank Rep. Decker and the people who worked with us about this maternal health omnibus bill. But it was March of Dimes in my first week on the job that sat all the women new legislators in 2019 and said, we have a problem in Massachusetts. And out of the 10 worst zip codes, 6 were in the city of Boston. And I remember leaving that meeting being like, 1, I don't want to die giving birth. But 2, remembering that it had happened in my family where my sister had lost her baby at 21 weeks. And I knew when I got in that elevator as one of 2 Black women that were sitting in that room, Rep. Lugardo and myself, that I had to work on the Black maternal health crisis. And that has led us to first year in having this commission. What Rep. Decker was talking about was that this commission is the only commission out of the 750 boards and commissions in the Commonwealth of Massachusetts that was majority people of color and had people of lived experience, not just practitioners, not just researchers. And they produced this report and had these 4 listening sessions that had over 1,000 people. And if you're like me, I'm wondering, how does the state with the best public health infrastructure in the world, I'd argue, best institutions, biotech, life sciences, entrepreneurial sector that rivals the West Coast, how is this still happening in Massachusetts? How are we closing birth centers? How are we closing pharmacies and maternal health wards all across this great state of ours? And so that really led us to focus on the people. I'm a former community organizer. I think you'll always be a community organizer. I was a WIC kid. I'm so happy these kids don't have to walk to the bodega to get their block of cheese anymore. But thankful to my Kicks and my Rice Krispies that I had every morning. I digress. But the point is that I know that power really comes from people. And also being a community organizer, I didn't want to tokenize people. So I didn't know enough about the Black maternal health crisis to focus on it. But what we did do was we took data from Black Mamas Matter. Ancient Song is an organization that focused a lot on doulas. And I had heard about the term doula literally the year before. I had never heard about what a doula was. I didn't know about birth centers until the Cambridge one closed, right? And so we take data and information from the people. It's not just the advocates and the organizations. And to speak to a point of how I've seen it work is it took us 6 years, right? 6 years from that commission, and we kept chugging along, working with different organizations. Planned Parenthood was at the table, Repro Equity Now, but we had people that were not in these organizations that were health related, right? Because we understand that, you know, health equity has a lot to do with whether you have safe housing. Health equity has to do with whether you have good food and it's affordable and accessible. Health equity has to do with if your neighborhood can fight gentrification and is safe for your kids to walk home from school. So we understood that we had to involve community organizations. And I just want to say that in the 6 years, we ended with this omnibus bill that was signed by Governor Healy. And what was an important piece of that is even though we had the data and we had the recommendations, I do want to shout out Governor Healy and her team. She went back to the Department of Public Health, said, I need more information. Is this a real problem? And I want to end with one of the things that happened. We found out that it got worse for Black women in the last decade. It didn't get better. So imagine being a legislator, you're working, you're bringing lots of different people to the table, and then hearing that it wasn't working. And so I think that the best examples are from community organizing. And I took a lot of the Dudley Street Neighborhood Initiative story about building community land trusts. People might not realize how that is connected to health equity, but in that movement, the power was given to the people to rebuild their communities because it was understood that they knew what they needed and they knew what they needed best. And so we did the same thing with the Black maternal health crisis here in the Commonwealth. And I think if more legislators did more community organizing work and building these organizations, that some are small, budgets don't even reach 100,000, but if they're partnered with the organizations that do have the resources, they get a lot done.
So thank you for that. And we here in the Commonwealth have spent quite a bit of intellectual power on this particular issue. And certainly I think are deepening our understanding and putting into practice the need for us to have structure that invites and welcomes community voice into the legislative process, into the policymaking process, and really does honor what we're hearing and what we're seeing. I'm curious, Dr. Hamad, based on your experience around the country, is it the same around the country, or is there more work to be done?
Yeah, I mean, absolutely. There's more work to be done. I think you've heard from our, local policymakers here about the amazing work that is done in Massachusetts. And, just to, the policies that I was talking about, the poverty alleviation policies, Massachusetts is one of the leaders in that realm. Separate from the federal earned income tax credit, Massachusetts has its own EITC. It has its own child tax credit, which is specifically for families with kids. So we, it's not perfect. There's always room for improvement, but we're really one of the leaders there. And, in a lot of the other states, they don't have their own EITCs or CTCs. They don't have as great a network of WIC clinics as we do here in Massachusetts. And so, and then there's also implementation problems. So, I mentioned that the EITC requires tax filing. That's sort of a complicated process, and actually only 4 in 5 families that are eligible for the EITC actually get it. And so there's a lot of, and in some states it's much worse than that. And so families are potentially leaving thousands of dollars on the table, leading to really big disparities in poverty, disparities in health. And so I think there's a lot of work to be done on the national level and in other states. For those of us in the audience, for those of you in the audience who are from outside of Massachusetts, to really close those gaps. And just to say it's not just geographic disparities. One of the reasons we're here is to talk about racial and ethnic and socioeconomic disparities, and those exist too. Again, going back to the EITC, this is the policy I work on the most. Our team has done work showing that the EITC has even lower take-up among families who don't speak English as a primary language. You can imagine that filing taxes is even more complicated for them or younger individuals. And so even, sorry, my papers keep falling.
You don't need it.
Don't need those. So even for people who aren't thinking about how can we change state and federal policy making, just thinking about folks who are on the ground, how you can make a difference, is working on those implementation barriers. If you work in a healthcare setting, can your social worker help connect people with the government benefits that they're eligible for? If you're in an academic setting, can you help do the research? Or even in a healthcare setting, can you help do the research to figure out what interventions work best to increase take-up of these government benefits and increase awareness so that people aren't just leaving money on the table? So I think there's a lot of work to be done by people at all levels to really try to reduce poverty and reduce health inequities on many fronts.
Dr. Goldstein, so I want to, as we're winding down in the last few seconds here, but I might take a little bit of privilege on this one. Because I do want to make sure that we touch on partnership, collaboration, team. That is a theme, a brand, a marker of the work that you have done and that the administration does. Because what we know is that our work to advance health equity is not about one organization. It's not about one bill, one piece of legislation, or one program or initiative. It really is about an ecosystem all moving in the same direction to achieve this goal of better health outcomes. In this moment, can you talk about the benefit of public, private, and academic partnership to help ensure that we continue to move forward?
I want to just call out that word team, right? And I'm really proud to be a part of the Healy Driscoll team. It really is true. Behind the scenes, they actually do talk like a basketball team. They're sort of pumping each other up. And it's really amazing to feel that energy. But it does transfer into all of the work that we do and the way that that Governor Healy has really directed the executive branch to reach out and engage with people. And now more than ever, as you know, we have to do this work. You know, we have been largely, in many ways, dependent on federal government, federal resources, federal convening, federal organizations to help us do some of this work. And we're not going to get that help over the next 4 years. That doesn't mean we don't have to keep doing the work. And so we're looking in the executive branch and the Department of Public Health, how do we reach out to community-based organizations and bring them in? How do we reach out to academia? How do we do a better job of sharing information? Information may be data, and that's really important for us to share, but it's also stories. It's understanding the impact of the federal decisions, the state decisions on the individuals who are coming in for care. You know, I think we're all exploring this new world together, which means we have the opportunity to build a better world together. And that world is going to be best built by having the right team at the table, the right faces, the right voices, the right representation. We have to do it intentionally. That's our goal in the Healy Driscoll administration. That's our goal in the Department of Public Health. And I'm looking out into the audience. These are the faces that we want. These are the people that we want at that table. This is the representation we need.
Rep. Decker, final word.
Final word. I think for those who are here who are trying to understand how are we tackling health equity, and I guess a few things I want you to know when you think about the legislature and how we do that. I've talked a little bit about sort of the partnerships. Filing good legislation, I always tell people, like, government doesn't move forward because of the lack of good ideas, like especially not in Massachusetts. It's about how do you pull together a team who can strategize and help prioritize. We can have up to 8,000 bills that get filed in the legislature, and it's a 2-year session. So, and we're a deliberative body. And I say all of that because we're only 130 days into the session, and yet the times that we're in, I don't think, while, you know, Project 2025, people understood it, I don't think I will say Trump 2.0, the speed in which things are coming in, right? And the speed at which really the goal is to dismantle government as we know it. And to be clear, to dismantle as we know it in one that actually harms very specifically people who are mostly not white middle-class men, right? Everyone else is like, and hetero, like everyone else is out. So what we are doing in the legislature and what we are doing in partnership with our executive branch and with advocates, many who are here today, is to say, how do we both show urgency, and then how do we also be deliberative? And these are like tensions that exist. I want to call out a few things that we worked on together, the commissioner and I. The Senate's about to do that. We just came up, Massachusetts has a history of being so many first. First in public education, first in health insurance for everybody, first in same-sex marriage, first in codifying abortion rights and gender-affirming care in our Constitution. We now just came up with, in the budget last week, we were able to, was able to put an amendment forward that will create a public health, a gender-affirming public health trust to ensure that while our hospitals are being threatened and we can't, and they're worried about losing millions of dollars in providing gender-affirming care, we will now have a trust in which we are exploring on how to provide that kind of care outside of the hospitals. When 26 states have banned gender-affirming care and many hospitals across the country stopped doing it out of fear. We have a poverty commission that is happening right now. You know, and we're doing it through the lenses of public health to say, what are the things that we can continue doing? EITC, Massachusetts over the last 10 years, we went from having 15% to 23 to 30 to 40% EITC. We're the only state in the country also that now allows, if you fled your batterer and you're married, up until we passed this part of a bill that I had filed, you had to be married in order to file, jointly file your EITC. You can now file your EITC if you have fled your batterer in Massachusetts and you're still married. Just to say that there's a lot of things that we have done and will continue doing. Our job is to, at the end of the day, make sure that good government is about government that works for everybody, that everybody actually is being strengthened and empowered and not harmed. So we're going to continue doing policies and budgets that actually show how to do that. We're going to continue working with advocates and working with people who are closest to the pain and whose lived experience is being represented and prioritized in the legislature. We need all of you to keep engaging us. We need to make sure that what's important to you, you are communicating. Do you know your state rep? Do you know your state senator? Make sure that you do and that they know what's important to you. Do you work for an organization? Do you work for an advocacy group? Can you be a resource to us and flag what's important to you? Like the collaboration, the urgency, and the deliberative body that we are will continue to be our path out of this. We are our best hope, and we're going to continue to show that government is a place that helps people and doesn't hurt people, even when it's falling apart around us. So I just want to say the fact that we're having this conversation, I know you're trying to wrap this up, but the fact that we're having this conversation, who here has been watching these panels all day? They have been amazing. They have been powerful, inspiring, and this is what's going to keep us going, because while they tried to suck the life out of us, right, I'm going to compartmentalize, so I'm going to suffer with all of us, right, and we're going to also compartmentalize. We're going to come together. We're going to be inspired by each other. We're going to be fired up by each other, and that's what's going to keep the resiliency going. So thank you, Tanisha, for all your leadership and all of your work, and to the people who I serve with, and to all of you. Many of you are here because you're doing really important work.
Thank you, Rep. Decker, and thank you to the entire panel. Phenomenal conversation. I have the opportunity now to bring up our final conversation, and that will be a fireside chat with Shirley Leong and Dr. Kevin Churchwell. So stay tuned. Thank you.